I'm Dr. Zulkarnain from the Department of Surgery. Today I'm going to demonstrate how to examine peripheral vascular disease and also peripheral venous disease. With me today, Dr. Ikhwan, who will show the clinical examination. Peripheral arterial examination. Before starting examination, please remember the mnemonics I PEEP. I, introduce yourself. P, ask for permission. E for explanation of what you're going to do. Another E for exposure of the appropriate parts. And lastly, pain. Ask the patient if there is any pain. Pause for a while and then you can proceed. Now let's begin our examination. Remember to examine patient in a warm room. In cold surroundings, the arteries will be vasoconstricted. Expose the limb for a while before start examination. We start with inspection. Please note the skin color, as this is the most noticeable, especially in people with fair skin. In patients with darker skin color, this might be masked and only little color changes can be noticed. The skin can appear white or marble or varying degrees of pallor, which become more obvious in the lower parts of the legs and the toes. Excessive deoxygenation of blood in the skin capillaries can give the foot a purple-blue cyanose appearance, which turns to white within few seconds after the patient lies down. Vascular angle. Now ask the patient to lie down supine if you have not done so. This test is called vascular of Berger's angle, named after famous Austrian surgeon. Note the skin color of the toes before you begin. Slowly raise the straightened leg and stop as the toes turn white. The angle in which the leg must be raised before it becomes white is called the vascular or Berger's angle. In normal person, a straightened leg can be raised up to 90 degrees and the toes will remain pink. What's the significance of this angle? This angle is directly comparable to the pressure in the small vessels of the foot. The height in centimeters between the sternum and the heel at the elevation of the foot becomes pale is approximately equal to the pressures in the foot vessels in millimeters of mercury. A vascular angle of less than 20 degrees indicates severe ischemia. Capillary filling time. Now you need to ask the patient to sit up and hang his legs down over the side of the couch. A normal leg will stay pink. An ischemic leg will slowly turn from white to pink and then flush purple-red, caused by dilated skin capillaries being filled with blood. The time taken for the foot to become pink is called the capillary filling time. This depends upon the degree of arterial obstruction. In severe ischemia, this can be as long as 15 to 30 seconds. The red-purple appearance is another indication of severity of the ischemia. Venous filling. In a warm room, the veins of the foot are relaxed and full of blood, even if when the patient is lying horizontally. In ischemic foot, the veins will be collapsed and appear like a gutter or a slit with pale blue in color in the subcutaneous tissue. This appearance is called guttering of the veins. The veins collapse when the legs are above the level of the heart, but if the circulation is normal, they do not empty completely. In ischemic limbs, the veins become gutted at 10 to 15 degrees of elevation. Pressure areas. Look carefully at areas exposed to pressure or trauma during walking or bed rest. These are first sites to show evidence of trophic changes, ulceration or gangrene. These areas are heels, malleoli, head of fifth metatarsal, between the toes where toenails rub the toes, and finally ball of the foot. Pressure necrosis will appear as thickened skin, purple or blue discoloration, blistering, ulceration, and or patches of gangrenous skin. Palpation. Temperature. Skin temperature can only be reliably assessed if both limbs are exposed to the same ambient temperature for a full 5 minutes. After exposing the legs or uncrossing the legs, it is unwise to feel the legs straight away. Expose the legs and perform other examination first. Feel the skin temperature with back of your fingers. This is preferable compared to palmar surface of the hands, which is usually warm and moist and not a sensitive temperature sensor. Move your hand over the whole limb. Note the cold and warm area and the level which the changes occur. Capillary refilling. Press the tip of the nail or part of the toe for 2 seconds and observe the time taken for the blanched area to become pink after you have stopped. This gives crude idea of the rate of blood flow in capillaries and pressure within. The blanched area usually appear pink within 2 seconds. Feel all the pulses. Femoral pulse. It is located at the mid-inguinal point, which is midway between the anterior superior iliac spine and the symphysis pubis. Popliteal pulse. There are 3 ways to feel the popliteal pulse. First, flex the knee 45 degrees and the heel resting on the couch. Place your thumbs on the tibial tuberosity and your fingers over the lower part of the popliteal fossa. Move your fingers side by side until neurovascular bundle is felt. It feels like a taut rubber cord. Press it against lower surface of tibia to feel the pulse. The artery cannot be felt above knee joint because it is deep between the condyles of femur. Second method, with the knee straight, place one hand behind the knee with fingertips along the midline of the popliteal fossa and hyperextend the knee against this hand and the couch with other hand. The third method is to turn the patient into prone position. Feel along the line of the artery with the fingertips of both hands. This is the most reliable method. Whenever you are doubtful about the presence of a pulse, check its rate against your own superficial temporal pulse to make sure you are not feeling your own pulses. Next, test the muscles and nerve. In severe ischemia, acute or chronic will cause loss of muscle and nerve function, producing an immobile and numb limb. Do a full examination of the functions of muscles of lower limb. Auscultation. Listen along the course of all major arteries. Part of the routine examination is to listen to the arteries in the neck, abdomen, groin, and thigh. Use bell of your stethoscope to listen along the line of arteries. Do not press too hard, as this can cause dent and stenosis and artificially created a bruit. Bruit is caused by vibration of the arterial wall induced by turbulent blood flow beyond a stenosis. Next, measure blood pressure in both arms to exclude subclavian or inanimate artery disease. Technique of examination of blood pressure will be shown in the next session of the clinical skill lab. Finally, reactive hyperemic test. Inflate sphygmomanometer cuff around the limb to 250 mm mercury for 5 minutes. Then deflate the cuff and measure the time taken for the appearance of red flush skin in the leg. In normal leg, it will take 1 to 2 seconds for it to appear red flush. In severely ischemic leg, it might not appear at all.